Welcome everyone to today's webinar, Telehealth Sustainability, How Northwell Health Built its Virtual Care Program for the Long Haul. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here for help. With that, I'm pleased to turn the floor over to Christine Mullen, the Business Marketing Leader for Connected Care at Philips, to introduce today's speakers.
Thank you so much, Morgan. I appreciate it. We're really excited to have such a wonderful panel here today joining us. First, I'd like to introduce Iris Berman. She's a nurse and nurse educator with more than 40 years of experience. She's been involved in Northwell's EICU since 2012. She's an active EICU luminary and telehealth thought leader, including membership positions and leadership positions on the ATA, as well as the Tele Advisory Board, focused on telehealth, e-health, law, and advocacy, and has also served as a past leader and speaker for the AACN and the American Heart Association. So welcome, Iris. In addition, we have Patrick McCarthy, who's the Assistant Vice President for Telehealth Services at Northwell, with more than 10 years of healthcare business experience. He leads Northwell's telehealth services since 2017, and before coming to Northwell, he had stints at Boston Children's as well as Dana-Farber Cancer Institute. So welcome both of you. We're really excited to learn more about what you and the team at Northwell have done in terms of your EICU and telehealth capabilities.
Thanks so much for the intro, Christine. It's a pleasure to be here. Next slide, please. Just a little bit about Northwell for those of you who may not be familiar with us. We are the largest healthcare provider in New York State and one of the largest nonprofits in the country as well. We consist of 23 hospitals, 750 ambulatory facilities, over 5 million patient encounters. We have 30% of the inpatient market share in the New York area, New York metropolitan area. We have over 71,000 employees. So understand that and the period of time with which we grew, and you may appreciate the scale and volume. Thank you so much. Next slide. To start with, and this was early on, this was just kind of our umbrella of beginning products with our vision in the early days. And I just wanted to give credit out to our entire team. Dr. Martin Dossler was really the visionary who realized the need for telehealth within our health system and hired me back in 2012 as the ops director for the EICU. And then the rest of our team, Patrick, of course, you'll hear from a little bit later, Cara Bennick, our clinical operations director, Dr. Merson, who was the visionary for our Telepsychiatry Program, Dr. Craig Hertz, who is our current medical director, and Dr. Jeet Gujral, who is our telehospitalist associate medical director. Next slide, please. So to start with, what we have is an organizational structure now. Now, I will tell you on day one, this didn't exist, but it became evident after about a year into the Tele-ICU that we really needed to pull things together as we started to see other possibilities in leveraging the beginnings of an infrastructure. This intricacy led us to realize that we needed experts on a variety of fronts. And so we started off by developing a clinical policy subgroup within a steering committee. So we really started with that Telehealth Executive Steering Committee and then spun off of that to include OCIO or collaborative technologies that had play anywhere in the telehealth process. We work very tightly with security, legal, and compliance is constantly with us every step of the way, clinical policy task force, and that's how we evolved into a real telehealth service area. To start with, back when we first started, and you'll see slides later, we only had EICU and a small smattering of program, which was a little bit in home care, a couple of locations for telestroke, and a couple of locations for telepsychiatry, and you'll see that growth. Next slide, please. So a little bit more detail about the IT organization and how it breaks out. And this is really important. You'll find that if you try to do this, and if you're building a larger infrastructure in particular, you need these components, or you need to be selecting the right kind of technology that helps you with those components. So please, pay attention to this. You will get a copy, a PDF, if you so need it, at the end of this presentation, so feel free to look through that. But what was really key to all of this was project and program management, to pull all of these moving pieces together on each facet that we rolled out in our telehealth program. Next slide, please. To start with, again, to give you an idea of how much we scaled, we started our full clinical operations in 2014 with only 2 hospital sites and only 40 some odd beds in an EICU, and that was what we had. We decided early on that we were staffing for 24/7 because we wanted consistency in the care model. We didn't want people to think, oh, if it's Tuesday, it must be Belgium. In other words, if it's this certain time in the evening, I have to call the ICU, and during this time I won't. We wanted a consistent level of care, and if you didn't need us, great, but we were always going to be there and available. Now, that could be expensive for some people, and there's varying models of this, but for us, it worked really well, and it helped with adoption of the program. We have 24/7 critical care nurses. We added in about a year and a half into the program advanced care practitioners, and then hospitalists, telehospitalist program. The advanced care practitioners started off in support of the Tele ICU during our busiest times. What you'll find in most locations where you're supporting a critical care unit is that the struggle becomes the times after the physicians go home. That's when things get busier, or in regions where there are less intensivists. So using those advanced care practitioners that are critical care trained helped us to extend our reach. And you'll see again, we are now up to almost 250 beds, and by year's end, we will be close to 350 beds or more. And so you need to understand and be planning for that scalability and supporting your intensivists. The telehospitals came on board then about 3 years ago, and that was strictly to support hospital admissions, to decrease bottlenecks in the emergency room, and to support the hospitalists. It became evident, though, that we could extend their utilization, and they were then brought in to support our tele-SNF programs. So we have 2 owned SNF programs, and I'll go into a little more detail as we get to the next slide. But you will see that we are multi-purpose and cross-support, and they do work collaboratively with our intensivists because it all sits in the same hub. We also then have our telepsychiatry program, and early on it sat in the same hub with us, but the program became so large, and again you'll see this illustrated, that they deserved and have their own hub now in Manhattan, and they are staffed 24/7 with care coordinators, LCSWs, and psychiatrists. Next slide, please. Within the acute care area, this is just a picture of one of our nurses in the core where our EICU is located. We began to realize that we could have further reach on the technology and bring other specialties into both the critical care areas and elsewhere in the hospital based on both our critical care platforms and our hardwired beds and mobile cart technology. So we added on all the programs I mentioned before. In addition, we have spun out pediatric critical care, neurocritical care consultation, trauma consultation, and pediatric ED, which has actually reached out now into urgent care, which is one of the last things we took on. And Patrick will speak more around the ambulatory side as we get further into the presentation. Next slide, please. So really, when you talk strategy, what became very apparent to us is we had to think about telehealth on a continuum. We happen to have started in the acute care realm. we have now since moved well into the direct-to-consumer or ambulatory and prevention and wellness. Urgent care actually was the last foray for us because we already had an agreement with Go Health. We have a JV with them, and so there were facets of that we needed to look at in terms of what could we actually handle, how scalable it was. And so our first move out has been actually in pediatric emergency care, and we work collaboratively with urgent care, and it's our doctors responding. That has just recently rolled out. But if you look at the thought, we said, yes, if we can plan for acute care, we need to now think about not just the specialties you see here, but what if I needed a dermatologist in the Tele ICU? I indeed would want to be able to integrate them, and how can I holistically do this so that the provider has a good experience as well, and how can we access from whatever location they're at to the acute care, decrease windshield time, look at levels of efficiency, and improve both patient and provider experience. Next slide, please. So if you look at stages of maturity of telehealth, some of you may be in various stages, some of you may not have started yet. I would say we're way up to stage 4 right now and heading into 5. We are consumer focused, but still building that out. And again, this is something that Patrick will speak about later in his presentation. But understanding your market has been what we've done a lot of time and interest and research in, and looking at that care delivery and what we really need. Now, it doesn't mean one size fits all, which is, may work if you're not a wholly integrated health system, but we are. So we needed to think strategically about who needed what in what locations. We serve a variety of suburban, urban, and one or two that lean toward more rural areas or farm areas that have very different needs. Our east end of Long Island has needs for almost every specialty. And so telehealth has become a hugely utilized way of getting care out to both the hospitals and for cross collaboration between the ambulatory practices out there. Next slide, please. Again, as I mentioned earlier, we started with a Tele ICU program, and our provider responsibility in our unit is around-the-clock support for all critical care patients that are covered. It is support for not just the patients, but for the bedside clinicians. We work with the on-site treatment plans every day. The primary provider is us when the bedside attending is off-site, meaning that the go-to who can write orders and help to manage the care plan in the busy times, as I mentioned, like say 4 o'clock at night until say 6 o'clock the next morning in most locations, is our physician on site with us in the core. The remote support of the plan of care. However, we always collaborate with the bedside. There is a handoff that is given daily, whether it be written or verbal, depending on the site and the census. We're also in charge, and the nurses work very collaboratively with the doctors in that unit, looking at trends and trying to be more proactive rather than solely reactive. And of course, we do respond to emergencies. We help to manage codes by being recorders, timing, introduction of medications and CPR, and our physicians also write orders and can manage codes long distance. Next slide, please. Just another slide. This is actually compliments of Phillips too. Thank you very much. But if you look at we talked about continuum, right? This is really about the continuum of care and everything I just mentioned. Next slide, please. Our Telepsychiatry Program, when we first started, was in its infancy, and it was at 2 sites, and it was on a different technology. It became very obvious that this was something needed everywhere, especially all of our community hospitals, and we needed to build it rather quickly, and we needed it to be scalable. So we moved to one single hardware. At that time, it was our mobile cards that were on the eCare platform, eCare Manager, which is our Philips platform, and we began to roll out TeleStroke on that platform, leveraged it that way, and this way we also had an integration back into EICU when necessary. Next slide, please. Then, as I mentioned earlier, we realized that the emergency departments were getting bottlenecked, and it was a big patient experience issue for us. Patients really felt unheard, unseen if they had to wait more than a certain period of time. And there were first orders that really were about basic comfort and basic initiation of care that could be met more efficiently by utilizing the telehospital, thus freeing up the on-site hospitalists to be running to the different needs on the different floors of the hospital. Remember, we have many hospitals and many patients. So we found a way to help leverage our centralized team to support that effort. So we are at all of the hospitals that you see right now. Next slide, please. We realized then that the Tele had some wiggle room, and so we were able to set up a Tele-skilled nursing facility program. We happen to own two nursing facilities, and we started there, and we worked very collaboratively with both nursing and medical leadership at the site. And we, again, started to support them on off hours when their other staff had gone home and it was just the nurses. For anybody who's worked in a nursing home, it is a godsend to be able to get care immediately and get eyes on the patient when you're not sure if they should go to the hospital or not. And for those sites, the loss of revenue by having to send a patient to the hospital is huge. Of course, we always want to do right by the patient, and that doesn't mean we always avoid a hospitalization, but we are supervising that care. And then because of the infrastructure that we built, we were able to leverage that same technology that was in the skilled nursing home, which was a mobile cart, also in the emergency room to continue to keep eyes on the patient when necessary by the same long-distance team and continue to manage their care and in some instances bring them right back to the nursing home. That became a very successful program. We ended up doing outreach, and we have two outreach customers that now purchase our services, and it has been very successful. During COVID, this has become a very important piece, in particular as the landscape has continued to change for nursing homes. We've also integrated family visits in some instances into some of those visits when we need to have difficult conversations or we need to review a plan of care, and we've helped to navigate those discussions as well. Next slide, please. And a little about our Telepsychiatry Program, which I mentioned is downtown and very successful, covers every one of our emergency rooms and has extended to what we call TeleCL in the hospitals. And you can see from this map, we are scattered across all 5 boroughs and into Westchester and Long Island. Next slide, please. And just to give you an idea of our volume, we are in the thousands. In the emergency department consults alone in 2020, we saw over 7,500 patients emergently. Next slide, please. Again, I mentioned that we had brought on initially some of those other specialties I mentioned earlier. We have since on our AMO platform and our mobile carts that we've extended to all of our hospitals, brought on a number of other specialties. Really, any specialty can come on right now as long as they have the access and the training to AMO. A big piece of this has been around training. Again, Patrick can speak to this, but we have created training modules that they must complete in order to have access to AMO. That's imperative so that both they and the patient have a good experience. But you can see, and I can tell you this list already grew since we made this slide. Next slide, please. So we're going to quickly go through our footprint. This is our footprint now, but just to give you an idea of the growth, can you go to the next slide, please? This is where we started in 2016. Now remember, that's already bigger than where we were in 2012. So, okay, all right, a few hospitals, a couple of programs. Now move on to the next slide. And you see in 2017, we've added on a considerable number. Still looks pretty clean, not much going on with telehospitalists yet. Next slide, please. In 18, 19, go ahead. Next slide. And in 20. Tremendous growth from 18 to 20, in particular from 19 to 20. Much of this spurred on because of COVID. It became much more necessary to be able to support the site. COVID was a definite eye-opener, and I know you've been hearing this and you'll continue to hear this. It has, I will tell you that I don't think Patrick's ever been busier in his career than he has been in the past year. But we have merged both Amwell and Philips programs into a total care package for the health system and still continue to think about continuum. And with that, I want to turn it over to Patrick, who will continue about our direct-to-consumer platform.
Great, thanks, Iris. And you can push it forward to the next slide. Yep, one more. There we go. So we at Northwell partnered with Avizia, which was acquired by American Well. We were originally working with Avizia, and that was sort of our solution for our direct-to-consumer platform. You can hit the next slide. Our goal, really, with American Well was to be able to connect a provider to a patient, no matter where the location was, and do it on one platform. So if you hit the next slide. So an example would be a pediatrician to a sick child in their home. We want to use American Well. To the next slide. If we wanted to connect a social worker to an elderly patient in a skilled nursing facility, again, we wanted to use one platform, which was American Well. Next slide. In the process of developing our work with Avizia and now American Well, we worked with them to create two different platforms. First, what we needed instantly out of the gate was an ad hoc platform. We leveraged their Connect program. It was a legacy product and now has been incorporated in American Well. The Connect allows us to send a quick message either via SMS, email, or to a SIP address or a device endpoint. This was incredibly useful as we had to scale up fast within the initial months of the COVID crisis. But at the same time, we were also building a full-on integrated product, and I'm going to get into that in a little bit more detail. Next slide, please. With our specific system, we actually have a lot of various different systems. So unlike a lot of the other hospitals in the area that have potentially one or two major medical record systems, we leverage Cerner for scheduling. We use Allscripts for documentation. We use GE for billing. We have a lot of different systems at Northwell. And with that in mind, we needed a telehealth platform that was going to work with all of our existing systems. Even on the highest estimates of potentially 20 or 30% of our ambulatory volumes transitioning to telehealth, we still need to use our same systems for the 70 or 80% of our volume that's not going to transition to telehealth. Next slide, please. With that in mind, as our physicians quickly adopted American Well last year, we wanted to create an overlap between our two systems. Philips is our system for our critical care patients on our floors, and American Well is our system for most of our other physicians in the facilities that allows them to connect to their patients on the lower acuity side. But we found that as you go from the acuity, from the lower acuity all the way up to the critical care patients, there's a need for the providers to be on one platform and to overlap those two systems. So we've been working with American Well and Philips to try and create that combination, and we're making progress on that. Next slide, please. Just because we're in 2021 at this point and we're still in the middle of the COVID crisis, we wanted to quickly touch base on COVID. New York was one of the first areas to be hit pretty hard by the COVID crisis, and telehealth was a big part of that, our effort to support our hospitals and our patients. It allowed us to, for our quarantine providers early on to continue to provide care back into the hospitals and to the ambulatory practices. It allowed us to limit the use of our PPE. It decreased the exposure of specialty services during consults. We kept patients pretty quickly in their homes instead of coming in and exposing others in our facilities. We used to connect patients in the hospitals with families without exposure, so we were bringing in patient families. Our ICU team was able to work with non-critical care staff, so as we had to increase our beds with some of the mandates of our state, we were able to then oversee some of these new floors and areas that didn't have the skill set or hadn't done critical care in a long time, and sort of support them. And then another sort of interesting thing too is we were able to leverage the same platforms for administrative staff to register and communicate with patients virtually. So we were not exposing our administrative staff when they were walking into our EDs. Next slide, please. Just quickly, so you guys can see some of the scale and the amount of projects that we jumped to really quickly, we paused in March all of our planned expansions and transitioned everything into projects that were directly related to supporting our COVID crisis. And so this is just a slide that sort of shows the rapid expansion of what we were doing. Next slide, please. On the ambulatory side, pre-COVID, we were doing a couple hundred visits a month. But quickly, we scaled from a couple hundred providers to almost 8,000 allied health professionals into our platform. We also scaled our volume significantly. So we went from a couple hundred to 3,000 to roughly 80,000 visits in the month of May on our ambulatory side. Next slide, please. Another thing that we sort of implemented in this, since we had a pretty mature and robust telepsychiatry program, our telepsychiatry program supported a number of different things that weren't originally part of our plan for the year. So they supported our Javits Center, they supported our COVID Transfer Center, they expanded their emergency telepsychiatry, so they covered a bit more during this, and they also changed a little bit of their structure to support some other hospitals and to also support the floors moving forward. Next slide, please. Just to make sure that you all are aware, we actually never stopped. So even though the COVID crisis slowed down a bit here in New York, we actually continued to catch up with our projects that were originally scheduled for the year. So we kept going. We knew that this was going to be important as we moved towards the end of 2020 and 2021 to continue to grow our programs and continue to build out our different systems and solutions. Next slide, please. And then lastly, the last 3 months of the year were pretty busy as well. We again started to see that once we had the infrastructure in place, we could quickly expand into different service lines and different support models for our hospitals depending on the services that they needed. Next slide, please. And this is sort of highlighting the fact that we grew into palliative care, toxicology, ophthalmology, infectious disease, hepatology. So we took on different service lines that we had not been working with before that we're now supporting our hospitals. Next slide, please. And that's really it. I think Philip says a few slides, right? So that's on to them.
Yeah, thanks so much, Iris and Patrick. You know, what an amazing sort of view of not only your rapid deployment in the core crisis of COVID, but also to share with us your roadmap and strategic sort of evolution and maturity as it relates to virtual care, enabling technology to really help provide care where it's needed, when it's needed, and how it's needed. As we sort of make a shift here, we want to really engage the audience. And so we're asking you to really help us in one or two words, really kind of drive where we take this conversation next. So if you'll just respond in the chat, you know, one or two words around what parts of telehealth sustainability are most crucial to your organizational success. And we'll leverage Patrick and Iris to really help facilitate this. But in the meantime, while we're waiting for the audience to respond, Iris, I would sort of maybe call it a question. You've been a strong advocate around and thought leader around sort of inequities and access to care, particularly in terms of the use of technology. You know, as you think about the pandemic and you think about your approach at Northwell, how have you enabled and leveraged virtual care to really help address some of the inequities that exist in access to care?
Well, I think that's a big problem that not just Northwell has to solve for. We have been in conversation, and we do have a population health and patient equity team that is working directly with the state, and we have government and state officials that we work closely with. And there's also the Reimagine New York campaign that we've been actively serving on, looking at accessibility, broadband access. In addition, in some of our programs, especially we're soon looking and embarking on Hospital at Home, we are looking to see how we can provide equipment to patients and provide their Wi-Fi for them. And we're hoping and having conversations with some of the major players in broadband to say, can we come to some kind of an agreement on either an affordable or a donated process for that accessibility care? Because remember, it's not just healthcare, it's education, all these kids that had trouble in these underserved areas. And then we also have to look around the regulatory bodies to help support that effort and to provide like a minimum viable product that allows for reliable broadband no matter where you are.
That's great, excellent. We're seeing several really good direction and questions coming in as it relates to the approach around virtual care. Several questions around, approaches to patients with chronic conditions, longitudinal care versus episodic care, and the like. As you think about your strategy at Northwell and as you think about, obviously, the expanded acceleration you've had and the reach beyond the EICU where you started, how do you think about bridging in and across not only access to telemedicine, where we have synchronous interactions, patient to provider, or asynchronous interactions to really kind of help move the needle, both in terms of health outcomes and costs?
So, I'll take it very quickly, and then Patrick, please chime in. The thing is, we've always thought about the continuum of care, even early on, and so connecting into a digital access point for a patient is extraordinarily important to be able to connect to the different facets of care that they have, and building an accessibility platform that works not just in telehealth, but to your point, remote patient monitoring is becoming quickly integrated into some of our programs, but particularly now for at home. For example, we have the Crown program. COVID taught us a lot about what we might do on a larger scale and continue to do after COVID passes. This isn't something that's just going to appear because of COVID. It's here to stay. Chatbots have become an extraordinarily important part for asynchronous conversation and information gathering. And so integration of all of those facets in through the DPX are super important to being able to maintain care. Making it easy to use is the biggest feat to overcome, and what we're working on day to day. Patrick, would you like to add anything?
Yeah, I would agree. And another sort of major thing about the continuity of care for our patients is, unlike maybe some other health systems, our telehealth system, we're not leveraging any outside providers. For us, it's about care with your provider as a patient. So you'll see your provider in person. Then if you're going to come in for a telehealth appointment, that should come in through the same, it should be coming from the same provider that you receive your in-person care. And on top of that, if a patient does need to go to our ED, et cetera, we can then connect in using the same technology to then provide that full continuity of care. We see that with our Telesnet program, and Iris, you could probably speak to it a little bit more than that, but we're able to do consultations to our skilled nursing facilities and also meet up with the patient via technology when they show up at the EDs. So there's a full sort of level of care and keeping and closing those loops to make sure that we're providing the best care for our patients.
I would add one other thing to that too. One of the other abilities that we have because of the technology we're using is to bring in other parties in the same way that we could bring a family into a crucial conversation and include families in the plan of care, by the way, is also to be out because they need the support and facilitation. We have a great geriatrics program which was up and running before we started COVID and got even more use during COVID. And families are more than willing to help facilitate. We thought that would be a problem, and these were underserved areas, but the families were more than happy as long as we could provide the technology. And initially when we kicked it off, some training around it. That's super important. You have to have support structures for this. But also we could bring in other parties, other members of the care team. So psychiatry along with maybe a home care provider to talk about plan of care or medication adjustment. So everything gets done in one time and much more efficiently. We had a pediatric case where we brought in, it was a complex chronic care child on a ventilator. We usually would have required traveling to each of the different specialties that she required. And instead, all of those specialties arrived on one call at one time and coordinated the care. You can't ask for better than that.
That's right, Iris. I mean, really great examples of how technology has enabled not only an improved patient experience, but ultimately your ability to react quickly, bring more of an integrative care approach delivering care to patients anytime, anywhere. So if you think about kind of the technology, obviously this was very foundational for you at Northwell, right? And so leadership, obviously, buy-in and support, but oftentimes health systems struggle with adoption and the change management required. How did you really overcome some of the roadblocks or barriers to adoption as it relates to whether a deployment to a new clinical area and really getting those physicians on board or the clinical staff on board and it being a fundamental part of how and where you will deliver care?
So the first piece of that is it continues to always be a job. It will never go away completely. There's always going to be a naysayer. However, if you can prove your value in whatever way, and getting data is the most important piece of this in some instances, if you put the numbers where your mouth is, instead I'm not going to say money, but the numbers where your mouth is, it helps because we're still having, we still need to get more on our ROI side. We're learning as we go, but the big motivator that dramatically changed everybody was COVID. And Patrick, I know you have something to say about this, so please chime in.
Yeah, no, I would agree. I think when our providers were thinking about the best care for the patients, and COVID sort of expedited that, was keeping those patients in their homes. So that sort of expedited our adoption and the different service lines that we worked with. The other thing too that sort of helped was reimbursement. Once reimbursement sort of came on, that allowed us to expand significantly, and we're now getting accustomed to it. Patients are getting accustomed to it. The providers are getting accustomed to it. There have been bumps in the road, as any new technology rollout has, but in general, people are seeing where it's going and don't want to go back. Another really important piece of this is that we have a program management team who does an excellent job of crossing their T's and dotting their I's on every new project that comes through. We work with our PMs on a regular basis. We define sort of our roadmap, and they do a great job of making sure that everything is in place and really sort of smooth things out. In addition to going live with a project, they support those projects sort of post-go live, which helps sort of smooth out any bumps that may come up during an implementation.
Yeah, and that ongoing check-in with the different service lines, we keep that on a regular basis so that we can hear about things before they become bigger problems, hopefully, and troubleshoot if there is an issue. It's really important to keep that communication line open.
That's great. Well, speaking of reimbursement, now might be a great time to pivot towards our regulatory and legislative panel. I'm joined by three colleagues from Philips. We have Evan Hoffman, who is our state regulatory expert. We have Monica Valenti, who is more at the federal level, and then I have Greg Fulton, who leads our market access and reimbursement. So, to team, Massachusetts recently passed legislation to protect and in some cases extend state telehealth coverage post-COVID. New York is another state, right, with similar legislation. Evan, how do we think about the legislative shifts, the passage here in Massachusetts, the inclusion, if you will, of both telemedicine as we think about the synchronous interactions, but also the asynchronous experience in terms of remote patient monitoring, changing and evolving with time?
Hi there. Thank you for the question. Just really exciting to be here with everyone. Again, Evan Hoffman, Director of State and Local Government Affairs for Philips. I'll say that the pandemic really brought telehealth and all the innovation surrounding it into the mainstream, right? In my world of state government affairs, honestly, telehealth is now a buzzword among lawmakers. If you just look in the last 2 weeks alone, the governors of South Dakota, Iowa, Virginia, New York, Arizona, and Missouri all tweeted about the importance of telehealth. We're seeing policy organizations like the National Governors Association releasing detailed policy papers advising governors on telehealth strategy. And I think you're going to see many governors talk about this in their state of the state addresses, like the Hawaii governor did last week and the Texas governor did 2 nights ago. 2020 is unbelievable in the amount of legislative activity we're seeing in the telehealth space. honestly, dozens of bills are getting introduced every day. I think in talking to the American Telemedicine Association just last night, they're already tracking over 300 bills of interest at the state level, which impact telehealth in one way or the other. So, you know, it's not going to be a stretch to say that probably every single state will consider some type of legislation in the telehealth space this year. As for some states I'm watching closely, I mean, you talked about Massachusetts' new law. You mentioned New York. I know the governor of New York had a press conference, so his telehealth package got a lot of media coverage. But also, you know, some states that I'm watching include California. Just a couple weeks ago, the governor's budget proposal conveyed a goal to cover remote patient monitoring for all Medicaid beneficiaries in California. In Texas, a state whose legislature really only meets every other year, there have been a flurry of bills introduced. Most of them are looking to expand coverage and reimbursement for private payers in Texas. In New Jersey, we saw legislation moving that would require payment parity for all health plans and also Medicaid. I would be willing to bet that in Pennsylvania this year, you're going to see bipartisan efforts to pass comprehensive telehealth legislation. There really isn't any in Pennsylvania right now compared to other states. Just earlier this morning, I was looking at Virginia, where we see legislation which would require Medicaid in Virginia to cover remote patient monitoring. So you can see from the map here, there's a lot of activity. We're tracking some of the laws that were passed in 2020, and the highlighted states are some of the other states where we expect a lot of activity this year.
Great, thanks, Evan. One last question for you. What are some of the state issues that they're prioritizing? Access to care, you know, provider coverage across state lines. What are some of those other considerations when we think about the emergency sort of bills that were passed as part of the Telehealth CARES Act that allowed much more flexibility? Do we think or expect that some of those more simplified and ease of use and adoption legislations will persist in some of the state activity that you're seeing coming about?
Yeah, great question. So states have a tremendous amount of power in creating the guardrails surrounding telehealth, right? They could influence how Medicaid looks at telehealth, how private payers look at telehealth, licensing rules. So I'd say there's probably at least a dozen large issues that you're seeing states tackle in the telehealth space. For example, as simple as how is telehealth defined? Is it only synchronous live audio video, or are states also covering asynchronous store and forward, remote patient monitoring, audio only? For example, this week alone, there were hearings in Washington State and in Arkansas on bills that would expand telehealth, their state's definition of telehealth to include audio-only modalities. A quick glance of my bill tracker shows that Georgia, Kentucky, Indiana, Louisiana, Maryland, Mississippi, among other states, are looking to expand their definitions of telehealth to include remote patient monitoring. Of course, another big issue that we're seeing states look at is who can actually provide telehealth. A lot of states will list the types of providers who can offer this care. We're seeing states look at, for example, adding physical therapists or occupational therapists or audiologists or dentists. We even saw one bill that sought to allow chiropractors the ability to offer telehealth. Another issue, of course, is licensing issues surrounding telehealth. A few things I wanted to call out here. In Arizona, the governor has been really outward in claiming that his state will be the first to open up telehealth to any licensed provider across the country as long as they are willing to follow certain state standards. We also saw the governor of New York want to create an interstate licensing reciprocity agreement for states only in the Northeast. And there's also a bill in Oregon, for example, that would permit Washington and California physicians and nurse practitioners and to practice in their state. And then I'll also say that there's a lot of bills surrounding reimbursement rules, as you mentioned. So do payers have to reimburse at the same level as if the service was in person, or can they negotiate with providers to provide other payment models? Like I said, this is going to be the primary issue we're seeing in Texas, but other states that are really looking at payment reimbursement rules include Connecticut, Iowa, Kentucky, New Jersey, New York, North Dakota, and Oklahoma. So there's just a lot happening, and if anyone wants more information about what we're tracking, what we're seeing, I am certainly happy to be a resource.
Great, thanks, Evan. As you said, the states are very influential and a lot of activity percolating here, but at the same time, the federal government is pretty influential and brought forth many sweeping changes, if you will, in 2020 as part of COVID. Monica, what are we seeing in terms of the 2020 end-of-year stimulus, or what we're seeing in terms of Biden's plans as it relates to telehealth and the benefits that it will extend to patients, providers, both in rural and urban areas?
Hi, this is Monica Volante, Director of Federal Government Affairs at Philips. There were quite a few telehealth provisions in the first three coronavirus bills that were passed last March, especially the CARES Act. A lot of the waivers that were present in those bills are only in effect through the duration of the public health emergency. What we're seeing now is legislation introduced in the last Congress and then in this Congress that would make some of these telehealth waivers permanent outside of a public health emergency. We've seen a lot of money going to rural areas, to tribes, to underserved populations. And the Biden plan, as you know, is about $1.9 trillion going through the House and Senate now. It does include additional money for broadband. In the end-of-year deal, we really saw an expansion of the money for telehealth. There was additional money for the FCC's telehealth program. There was additional money for just building out the infrastructure of broadband. So I think that is going to be one of the things that we see coming up in the next year. If there's an infrastructure package that goes through Congress, I think for the first time that might actually include broadband deployment, not just the highways and ports and things like that. But we're also seeing a lot of money going to rural areas. I think there's also going to be, like I said, a focus on extending some of the telehealth waivers, but also giving a reciprocity for licensing across state lines, at least for the duration of the public health emergency, for people to provide telehealth services. Even that could lead to something permanent, although I'm a little bit less optimistic about that at this point.
Great, Monica. Any other healthcare policy trends that you foresee in 2021 that would influence sort of our ability to, or our focus and shift around virtual care and the enablement of technology to help really move care, certainly across the health system, but also maybe outside the healthcare system to home settings?
There is definitely talk among the committees of jurisdiction in Congress about moving telehealth to the home setting. There's also been provisions about physicians in the last bill. So I think you're going to see some of the trends that we talked about, but you're also going to see an acceleration. Telehealth was obviously here before the COVID pandemic, but to be honest, many members of Congress were not focused on it. I think the pandemic just accelerated something that was already there, and there are so many members that are now interested in this issue. There's a Congressional Telehealth Caucus. You have members like Mike Thompson from California, Democrat. You have Bill Johnson, Republican from Ohio, Dave Schweikert, Republican from Arizona, Peter Welch, Democrat from Vermont on the House side that are very interested in these issues, that are putting out plans for telehealth policy going forward. It might not be in the form of specific legislation yet, but they are outlining plans of where they'd like to go. In the Senate, Senator Brian Schatz, Democrat from Hawaii, and probably Roger Wicker, Republican senator from Mississippi, are probably the two leaders on telehealth. So I think this is not just in the minds of many members of Congress, something that is out there in the future or something kind of nebulous. It is a lot more concrete for them. They understand why it's important now, and while they may not understand the intricacies of how all of it works, they know that we need to speed up our adoption. So just the change in attitude towards telehealth, I think, is going to bring about a lot of advances in the coming year.
Thank you so much, Monica. Reimbursement is one of those topics that can perhaps be the most intimidating. We heard Iris and Patrick talk about the fact that that was actually one of the pivot points of adoption and the pivot point for them in terms of expanding services. You know, as we think about this topic, Greg Fulton, who leads our market access and reimbursement area, how do we think about the horizon as it relates to reimbursement and really sort of the overall impact and approach over the next couple of years?
Yeah, thanks, Christine. Hi, everyone. There is some news in terms of reimbursement. Monica touched on it in terms of the PHE, the COVID waivers. And in case I want to go through that news, in case anyone here on the audience did not see it, the outgoing administration earlier in January, they did extend the COVID public health emergency waivers through April 21st. You know, they're doing it in these 90-day increments. So right now, all of those COVID waivers, if you go back to last spring, this was when CMS introduced more than 100 CPT codes for telehealth ambulatory into the physician fee schedule, a lot of use cases. I did see in the chat someone was noting that cardiac rehab was one of those. So do take a look back at all of those use cases and all of those telehealth reimbursements that were introduced for the COVID PHE. Right now it's extended through April 21st. But then on January 21st, the new HHS administration sent a letter to all the nation's governors saying that we expect, and it is likely, those were the couched terms they used, to go ahead and extend the COVID public health emergency waivers all through the entire rest of 2021. So we anticipate that will happen. So once again, look at all of those waivers, not just telehealth. Patrick touched on the growth of ambulatory telehealth that Northwell experienced. All of those, the remote patient monitoring waivers, all of those are looking to extend likely through the end of this year, but we'll be watching for that. Again, right now, what's permanent in place through April 21st. What CMS did in the meantime in the physician fee schedule for the 2021 final rule, they took some of those COVID waiver telehealth codes and made them permanent into the fee schedule. So those are paying now. There was about 9 telehealth codes that they put in. They also put 13 others in what they call a Category 3. The language around the Category 3 meant that those would stay relevant or be reimbursed through the end of the year in which the PHE extends. So if you look at that language, that means those codes now, too, are permanent at least through the end of 2021. Again, the same for remote patient monitoring and some other aspects like that. Would also touch on the idea that if you look through the fee schedule, don't take it to mean that those, again, are just going to be your ambulatory patients or your patients in the home, whereas those waivers did allow telehealth in the home, waiving of copays, things like that. If you look back into those waivers, there is also language for hospital-owned employees to be able to do telehealth from their home, ambulatory surgery centers as hospitals, a lot of language to go back and take a look at, as, again, we expect these waivers to extend indefinitely to this year. The last thing that I will mention, sort of looking ahead, if you look at the fee schedule, Northwell spent a lot of time, rightfully so, talking about EICU or critical care ICU. These are their inpatient beds. There is some news on the horizon out of the fee schedule for that would fit that centralized model. Back in October, the American Medical Association put forth 4 codes to the CPT editorial panel, not in time for the 21, but certainly looking at the 22 fee schedule final rule. These are CPT codes, and they framed them as, quote, remote critical care services, Tele ICU codes. This will be for the reporting of remote intensive care and critical care unit services provided by a centralized critical care team, critical care physicians, and or qualified healthcare professionals. So really what this means is, as if you've got a centralized model to tele-ICU, it's going to provide direct reimbursement through the physician fee schedule. That way you're sort of not looking to see where telehealth codes might cobble in or be able, which they do and which they can. But I think there's some good news ahead on real direct reimbursement for EICU as well. I'll stop there looking at the time we have in the hour, and if there's any other follows from me or for all of the panel. But I think those are really the highlights coming out.
Great, thank you. I appreciate that, Greg. And really, obviously the legislative landscape is quite diverse and moving quickly, so I appreciate that. And looking at some of the questions that came in broadly around from the audience, I want to just maybe in the last few minutes here address a few of them. So Iris and Patrick, there was a question that really is wanting to understand the difference between your tele-ICU and your tele-critical care program. Could you add a little bit more color and definitiveness there?
So our Tele-ICU program is our program directly into our ICUs from our centralized core, and is inclusive of our hardwired Philips eCare Manager platform and collaborative with the bedside team and supporting the bedside team. Our Tele-ICU consults, or critical care, we call them tele-critical care consults, to make the distinction that these are consults occurring outside of the ICU, and those are the types of consults we are able to bill for, and they must be ordered by a different specialty. So the hospitalist or the emergency room physician asks for a critical care consult, and those are billable at this moment in time. Patrick, did I leave anything else out?
Nope, that's correct.
Great. The other question that came up that certainly we're seeing from the audience is you guys have had such a robust, acceleration and expansion of your program, but what's up next for Northwell as you think about, the end of 2021 and beyond as it relates to virtual care and telehealth?
So we're heavy into exploring remote patient monitoring right now. At the moment, we're involved in a pilot for a particular product, and this is really a pilot to look at both inpatient remote patient monitoring, and we're preparing to help support hospital at home and still exploring what types of modalities we'll use. But we expect to use our center of operations, our core, to support all of those types of programs and centralize that resource as well to make it more economical for everyone.
Great.
Yeah,
and maybe finally, go ahead, please.
Oh, sorry, if I could jump in, if you don't mind. If you're familiar with the CMS Hospital at Home program they launched in November, that program also can only exist during the public health emergency. They're not going to launch an ambitious program like this if the PHE is going to end in a couple of months, in my opinion. So,
correct.
Correct.
I'd agree with that. I agree. We're looking at it even beyond that, though. We're seeing a need.
Indeed.
Yeah, and maybe finally, for the conclusion of our events before we turn this back over to the folks at Becker's, is just really trying to understand how you guys are using and leveraging the data and information. You talked about sort of the importance of data as it relates to ROI, but how are you taking sort of the data across to really help inform and influence whether it's next best clinical action or really ensuring the stickiness such that a patient had a telehealth encounter and doesn't show up at the ER or ED? Like, how are you guys thinking about sort of the use and leverage of data in Northwell?
So I think, we both, Patrick and I, are looking at this both on the ambulatory and the acute care side. Particularly, as I mentioned earlier, we are seeing a reduction in visits to ER from the use for things like telesniff, and we have data to support that. The at-home, we're just starting to explore that now, and being able to collect that data, but also the encounters themselves and that data is very important in terms of, does in fact telehealth visit at home decrease the level of acuity of care needed further on if they do get their care earlier. And that's one that's a little harder to crosswalk, and we're trying to pull all of our different databases. You saw that slide that Patrick showed. We have a lot of systems to pull from. Patrick, did you want to add anything to that?
Yeah, I would say we also look at our operational data on a regular basis.
Right.
So when we're looking at an integrated solution for our patients, it's not just a phone call anymore. It's now, do they have an account? Have they done everything that they need to do from a paperwork and administrative perspective? Have they launched the button? Has the video been successful? Have we documented it appropriately? Have we dropped the bill? Like, there's a full lifespan of an encounter that we need a data point for every piece of that.
It's super important to get to know these things, because we know that HHS is looking for this data, because one of the concerns, they just expressed it in a meeting I was on with them 2 weeks ago. I was listening, not speaking, but one of the members of HHS did express concern that it might duplicate visits if you can't get the visit done at home, that patients will still wind up in the office, and they don't want to create additional billing for the same issue. Our answer to that has been, if you do this right, you're properly triaging your patient, you will avoid duplication and decrease escalation. So it's incumbent on all of us as health systems out there to keep and figure out a way to track this data and look at our claims data and crosswalk it, so that we can say, in fact, that we have been able to save it and compare it to same time, of a different year before we had the telehealth integration, for example, and show impact. That's going to take some time to call out. It's complex, but it's what we need to do.
Well, thank you. What a great session here. I'm going to turn it over to the Becker's team to close this out.
Thanks, Christine. Yes, that's all the time we have for today. And I want to just give another thank you to Iris, Patrick, Greg, Monica, Evan, and Christine as well for a really excellent presentation today, and also Phillips for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.